You want to know if the test is positive, how likely is the patient to have the disease, and if the test is negative, how likely is the patient to have the disease. Likelihood ratios tell us the ratio of the chance someone with the disease tests positive to the chance someone without the disease tests positive. Positive likelihood ratio, abbreviated LR+, tells us how much to increase the probability of disease if the test is positive. It's the probability of a person who has the disease testing positive, the sensitivity, divided by the probability of a person who does not have the disease testing positive, which is 1 minus the specificity. Negative likelihood ratio, abbreviated LR-, tells us how much to decrease the probability of disease if the test is negative. It's the probability of a person who has the disease testing negative divided by the probability of a person who does not have the disease testing negative. A likelihood ratio greater than 1 indicates the test result is associated with the disease. A likelihood ratio less than 1 indicates the result is associated with the absence of disease. Before ordering a test, if you're a clinician, you always need to consider how it will affect medical management of the patient, and likelihood ratios help make this determination. This is also important to understand if you're going into public health and may be designing screening programs, but are not a clinician. The higher the likelihood ratio, the better the test is for ruling in a diagnosis, and the lower the likelihood ratio, the better the test is for ruling out a diagnosis. It's important to note that likelihood ratios are determined only by test sensitivity and specificity. They're characteristics of the test. They don't change based on prevalence in the population you're testing. Predictive values are very relevant clinically because they answer the question, if the test is positive, how likely is it that this particular patient has the disease? Pre-test probability is the chance of having the disease before getting the test result, which is determined by the prevalence in the population and also takes account the individual's risk factors. Bayes' theorem tells you how to adjust pre-test probability to post-test probability. When you get a test result, you don't throw out the pre-test probability, you adjust it to interpret test results. Positive predictive value describes how likely it is that a positive test result in a given patient population represents a true positive. And negative predictive value describes how likely it is that a negative test result in a given patient population represents a true negative. We have to interpret test results in light of the risk group the patient comes from. High positive predictive value is very important for a disease for which a positive test result will result in invasive follow-up. For example, we don't routinely screen for ovarian cancer, but if we think that someone does have ovarian cancer, surgery would likely be necessary to confirm the diagnosis, which would be a high-risk intervention for the individual. A good rule of thumb is that a positive predictive value of at least 10% is needed to justify a screening program. If 9 out of 10 positive test results are correct, meaning they're true positives, then the positive predictive value is 90%. And if 7 out of 10 negative test results are correct, meaning that they're true negatives, then the negative predictive value is 70%. To explain predictive values, I'll turn what we talked about before on its side. Now the blue shaded area is horizontal rather than vertical. This time, the information we know is whether people got a positive or negative test result, rather than if they actually have the disease or not. I know this may look complicated for some of you, but I'm showing the formula here so you know how the simplified equation was derived. The probability of the disease given a positive test is equal to the probability of a positive test if you have the disease times the prevalence divided by the probability of a positive test if you have the disease times the prevalence plus the probability of not having the disease times 1 minus the prevalence. P of B is the probability of a positive test result. The denominator of the longer version has true positives plus false positives because it's the probability of someone getting a positive result regardless of if they have the disease. This formula is for use when you have percentages rather than numbers. For example, prevalence of the disease rather than a count of cases of disease. Here's a practice question. To study this new test, I enroll 1,000 people with brucellosis and 1,000 people without it who have not consumed any caribou meat as a control group. After testing my study participants and calculating the sensitivity and specificity, I calculate the positive predictive value. The Alaska Department of Health contacts me to assess feasibility of a statewide screening campaign. Can I share the positive predictive value I calculated when helping them determine whether the screening test should be used for all Alaskans? Why or why not? No. In this instance, the positive predictive value will be way higher for this artificial population because the exposed group and the control group without the disease were the same size. So the prevalence in this artificial study population would be 50%. This is very different from a real situation where you would be testing a population of people whose disease status is unknown. In real life, you can look up the sensitivity and specificity of a test and the disease prevalence in the community you serve, but you have to calculate the positive predictive value because it's unique to your population. Predictive value is not a fixed characteristic of the test. For this example, the brucellosis test has a sensitivity of 99% and a specificity of 95%, and the population is 10,000 people. So we put the population total in the lower right-hand corner. Since we know the prevalence is 1%, we can multiply 10,000 by 0.01 to determine that 100 people in the population have brucellosis. We put this total below the column for those with the disease, then we subtract the 100 people with brucellosis from the total population to determine that 9,900 people do not have brucellosis. Next, we apply the sensitivity of 99% to the 100 people with brucellosis by multiplying. So 99 people are correctly labeled by the test as having brucellosis, and one person was incorrectly labeled as not having it. Then we multiply the specificity of 95% by the people who do not have brucellosis, 9,900 times 0.95, and that gives us people that are correctly labeled by the test as not having brucellosis. Then we subtract from the total people without brucellosis to determine the test would incorrectly label people as having brucellosis who don't actually have it. Then we can calculate our positive predictive value by dividing the true positives by the true positives plus the false positives. The test correctly labeled 99 people as being positive for brucellosis who do actually have the disease, so it's 99 divided by all the people the test labeled as being positive, which you can find by adding across horizontally. And that gives us a positive predictive value of 17%. So if a patient comes in from this population and they get a positive test result using this particular brucellosis test, there's a 17% chance they actually have the disease. Now let's look at what happens when we increase the brucellosis prevalence in the population from 1% to 5%. If we go through the same steps using the 2x2 table format, we then get a predictive value of 51%. So you can see when prevalence increases, the effect on predictive value is dramatic. Now let's look at the relationship between negative predictive value and disease prevalence. Negative predictive value is the true negatives divided by everyone who gets a negative test result, the true negatives plus the false negatives. With this test, when the brucellosis prevalence is 1%, we get a negative predictive value of 99.98%. And when the prevalence increases to 5%, we get a negative predictive value of 99.94%. So you can see from these examples that the negative predictive value isn't as dramatically impacted by an increase in prevalence compared to the positive predictive value. The positive predictive value is much higher in a population with a high disease prevalence. When something is rare, false positives will skew it a lot, but when it's common, the true positives are closer to all positives. This means it works well for conditions that are relatively common in the population, but it's less accurate for conditions that are very rare in that population. When deciding who to screen for a particular disease, it's especially important to have a high positive predictive value if a false positive test result will lead to invasive follow-up. A screening test is more likely to cause harm if the positive predictive value is low, for example, less than 10%, for the individual patient based on their characteristics such as gender, age, geographic area of residence, occupational exposures, and family history. This graph predicts that relationship between predictive value and disease prevalence, which isn't linear or entirely intuitive. Here's another practice question. If 80% of women with breast cancer have positive findings on a mammogram, then the probability that your patient whose mammogram just came back positive has breast cancer is 80%. True or false? After watching this lecture, you should recognize that the probability of someone with a disease testing positive is the sensitivity. But to know the probability that a patient's positive screening test result represents a true positive, that they actually have the disease, requires the positive predictive value, which uses the prevalence in the population. If the positive predictive value for screening mammography in American women aged 40 to 50 is 0.04, and your 45-year-old patient gets a positive test result, what are the chances she actually has breast cancer? 4%. The positive predictive value is the proportion with the positive tests that actually have the disease. Positive predictive value describes how likely it is that a positive test result in a given patient population represents a true positive. Continue to the third and final part of the lecture for more about preventive health screenings.